All right, so we are 10 o'clock on the dot, so let's get started. So for those of you who don't know me, my name is Courtney. I'm one of the nurse educators here at NCLEX Bootcamp. My history is in psychiatric and mental health nursing. I've been a nurse for 15 years now and a psychiatric mental health nurse practitioner for 7. We're also joined today by Dr. Amber Adams. She is moderating our chat, so you'll see her posting comments and links throughout our time together today. So if you want to pop in there and tell her hi and make sure you leave her a little note, I'm sure she'd love to hear from you. And of course, if you have any questions as we're going through some of these practice questions as well, go ahead and leave her a comment and then she can answer any questions that you might have. There is a little bit of a delay sometimes between the time you post it and the time she sees it. So if she doesn't answer back right away, don't worry. Sometimes there's just a little bit of a lag and she'll get to it. Let's get started. So this is going to be our rundown for our time together today. We'll probably have about 30 to 40 minutes together. So this is going to be a live study session. So I've picked some sample practice NCLEX questions for you. We're going to go through them together, talk about how to approach these questions, think about them like a nurse so that you can feel really confident when you're going in to take the NCLEX. And it looks like I'm seeing from a couple comments, some of you are taking your NCLEX pretty soon. So hopefully you find this helpful. So today we are focusing on single best questions, and that is because this is the most common item type you're going to see on the NCLEX. So of course we have our select all that apply questions, our bow tie questions, our case studies, but those single best items are going to be the ones that you're going to see the most of. And they can cover a wide variety of topics from pharmacology, adult health, pediatrics, specialty topics like OB and mental health. So I picked a couple of questions for you today that kind of a wide range of those questions. We're going to talk a little bit about how these items are scored. It's really simple. And then we're going to talk a little strategy about how to approach these item types in a way that will help you be successful. Single best item types, they're scored very, very simply. It comes down to if you get the answer right, you get 1 point. If you get the answer wrong, you get 0 points. So it's not like a SATA where there's multiple points involved. It's just a 0-1 scoring rule. So how do we approach these questions in a way that's really going to help you be successful? So the biggest, most important piece of advice that I can give to you is to make sure that when you're taking the NCLEX and when you're doing practice questions is to read the header and read that stem very, very carefully. And the reason I say that is because the NCLEX stems can take a couple different forms. And if you don't read them really carefully, you could end up in the situation where you might get that question wrong even if you know your stuff. So let me give you an example. We might get a stem that says which of the following actions by the nurse would be appropriate, or which action should the nurse take. And so that means we're looking for a correct answer option, an appropriate task or an appropriate action, which means one of those answer options is going to be correct and 3 are going to be incorrect. But we might also get a prioritization type stem, which might say something like what should the nurse do first, which is most appropriate, which is most concerning. And so in these item types, we might see that all 4 answer options are correct actions to take, but only one of them is going to be our highest priority or most important or most appropriate. Okay, so we have to read those really carefully. And then even still, we might get another stem that says something like which of the following would cause the nurse to intervene, which means that we're looking for an incorrect action, which means that 3 of those options are going to be something correct that you could do, and 1's going to be incorrect. And so we have to find the one that's going to be incorrect. So you can see that if we don't read these really, really carefully, we might pick the wrong answer option. And I've been guilty of doing this myself, so I can speak from experience on that. And then from there, I always like to stop and ask myself, what do I already know about this topic? And the reason I do that is it helps keep the information straight in my head and helps me not get distracted by the distractors. So let me show you what I mean. So say we were getting a pharmacology question, and I'm a mental health nurse, so I like my mental health meds. So say we got an answer or a question on fluoxetine. If you guys can help me out in the chat, tell me what kind of medication is fluoxetine. I like to do a little brain dump of what I already know about the topic I'm being asked about. So what do you guys think? What kind of medication is fluoxetine? It is a mental health med. This is an SSRI, right? A selective serotonin reuptake inhibitor. So then I like to think, okay, what are some common side effects for this medication? What are some common side effects of SSRIs? We might see GI upset, nausea, diarrhea. We might see headaches. Sexual side effects are really common with this class. And then how long do they take to work? Do people just start taking it and they're like, oh, my depression was gone overnight? Right? It takes a couple weeks to start working. And then what's kind of the big concern we have, the potentially fatal side effect that can happen with these medications? Serotonin syndrome, right? So all already I can say, okay, I know quite a bit about fluoxetine or SSRIs. So from there, then I like to go through and start ruling out my answer options. So the reason I do this, like I said, is it helps me to not get distracted by my distractors. So say I was reading through that question and it was asking me about what kind of education should I provide to a client who's going to be prescribed fluoxetine? And what if it said something about this client needs to avoid tyramine containing foods? And I'd be like, oh, that sounds right? But it would be right, but it would only be right if we were talking about an MAOI, right? Not an SSRI. By brain dumping kind of what I know, it helps me to not be distracted by other things that might be true for other classes, if that makes sense. So from there, I like to start ruling out my options. So are you ready to put this to the test? Should we do some practice questions together? That's why you came, right? So I imagine the answer is yes. Our first question is going to be a prioritization question. Now, I told you Dr. Amber Adams is over there in the chat, and she has done some really fantastic webinars on prioritization and delegation. She's got another one coming up in a couple weeks. It looks like the week of February 10th, but if you want to go back, they are archived on our YouTube channel, so you can go ahead and watch those if you're interested. They're really fantastic, prioritization and delegation, because I know those can be challenging topics on the NCLEX. So in this question, we are a nurse and we've become aware of the following client situations, and we're being asked which one of these clients should we give priority to for intervention. Okay, so when I think of priority intervention, I like to think about which one of these clients is at the most imminent risk for harm or at the most imminent risk for adverse health outcomes if I don't intervene right away. So to help us better understand prioritization, let's jump over and take a look at our very handy prioritization pyramid, and you can find this on our prioritization cheat sheet over on our website. And so this is just a really helpful graphic to help us move through thinking through prioritization questions. So I like to start over here on the left and work my way kind of to the right and down. So we always start by eliminating any stable or chronic issues. And so we often see, for example, maybe like a client with heart failure or COPD, and they're having dyspnea on exertion. We often see this as a distractor, right? But dyspnea on exertion for a client with heart failure or COPD is something that we would expect, because heart failure, COPD, these are chronic issues, right? And so we know it's not good, but I think to myself, is this likely to be imminent risk to their health or well-being in the next 8 to 12 hours of my shift? Probably not, right? It's a chronic issue. It's going to keep going on for a long time. And then from there, we can rule out any expected findings, routine tasks, or psychosocial needs. And the psychosocial needs often pop up as distractors, and these could be things like maybe we have a patient who is upset because they're having to wait, or maybe they're having financial difficulties, they can't afford their medications. So we're not saying that these aren't important. They are, of course, very important, but they're not going to cause an imminent risk to that patient's health or well-being within the next few hours, right? And then from there, we move into things that are a little bit more emergent. So neurological, circulation, breathing, right? Those have the potential to be a little bit more life-threatening in the next few hours, right? And then we have at the very bottom our airway and safety. And this makes a lot of sense, because if a client has an airway occlusion, right, maybe they have swelling in the neck area, they can't breathe. How long do we have before this is going to become a very real health issue? Not very long, right? We maybe have minutes at best to intervene before this could become potentially fatal. And then same with safety. If somebody is showing signs of imminent safety risk, we only have a very short time to intervene before we could see potential harm, right? After kind of thinking about all of that, let's go back to our question and see if we can figure out which one of these clients we should give priority to. So first off, it looks like we're on a mental health unit, because it looks like all of these clients have some kind of mental health diagnoses. So our first client is a client diagnosed with depression who's refusing to get out of bed to eat. What do you think? So why are we not so concerned by this client with depression who's refusing to get out of bed? Is it unexpected to have a client with depression who wants to stay in bed all day? Now, that's a pretty expected finding with depression, right? And remember, we don't want to add any information to the question we don't already have. So we're not being told that this client is severely underweight and that not eating would be some kind of imminent risk to their health. So they might need a little bit more coaxing, right, to get out of bed. We might need to provide them with a little bit of encouragement, but this doesn't sound like an imminent risk to their health or safety, right? So next we have a client with a manic episode who's telling telling her peers she belongs to the royal family. What do we call this? Delusions of grandeur, right? Yes, and so that's a very common finding with clients experiencing mania, right? So we might often hear them talking about how they're famous, how they're very important, right? They belong to the royal family, things like that. And so does this pose an imminent risk to this client's health or safety? Her peers might think she's a little off, a little strange, right? But not necessarily a big safety concern and an expected finding with mania, right? So I think we can rule out these first two options. Next, we have a client admitted for severe opioid withdrawal who's reporting muscle pain and diaphoretic, so they're sweaty. I see a couple people who are picking 3 as their most concerning or highest priority intervention. So remember, this is a priority style type question, so we're saying that all of these clients, we need to address all of them, right? Because they are our clients, but only one is going to be the highest priority. This is the one we're going to see first. What do you think about opioid withdrawal? What are common symptoms of opioid withdrawal? So usually when I think about withdrawal, usually the withdrawal symptoms are opposite what intoxication causes. So opioids are CNS depressant, and so when people withdraw from them, they often feel agitated. We often see muscle pain, bone pain, they sweat a lot, they have that runny nose, runny eyes. But is opioid withdrawal fatal? Is it typically fatal? Is it as dangerous as alcohol withdrawal? No, right? So people withdrawing from opioids, they will tell you that they feel like they are dying, and they probably do, right? It's very, very unpleasant, but it's not typically fatal. And these symptoms of muscle pain and sweating are very common symptoms with opioid withdrawal. So these are expected findings. So we're going to need to address this client, and a lot of times they might give like clonidine to help reduce those symptoms of withdrawal, but it's not going to be an imminent risk to their life or safety. They're just going to feel really, really crummy, right? Okay, but let's see what we have for number 4 to see if that's rating any higher on our scale. We have a client with schizophrenia who is pacing and looking suspiciously around the day room. What do you guys think? I see a lot of people pick this one as the one you're most concerned about. Can you tell me why? Why are you most concerned about this one? I'm concerned about this pacing and this looking around suspiciously because these are signs of increasing agitation. And what do we know about clients with schizophrenia? They're often having delusions, hallucinations, right? And so they are not thinking clearly, and they can be paranoid, and this can cause them to act in very unpredictable ways. And so when we're starting to see signs of increasing agitation, we need to intervene really quickly so that this does not continue to escalate into more aggressive behavior, because these clients, they can act out if they feel like their life is being threatened and they're not thinking clearly, right? So we need to intervene right away. So I'm liking this one as the most imminent safety risk, and it looks like a lot of you are seeing that as well. So good job. Should we take a look to see if we're right? Yes, we are. Okay, so let's move on to question number 2. So this is a pharmacology question. How are you guys feeling about pharmacology? I feel like either people love it or hate it. Either they're like, I know it, I'm solid, or they're like, ooh, it's really kind of a struggle. I like pharmacology myself. I think it's fun. Okay, so in this one, we have a 76-year-old female client who was recently prescribed hydrochlorothiazide. So we're being asked which of the findings would be most concerning. So again, this is another prioritization type STEM. We are saying that all of these findings are concerning, right? But which one is most concerning? So to answer this, we need to know some things about hydrochlorothiazide, right? That's where we need to start. We need to start with what kind of medication is this? What is hydrochlorothiazide? This is a diuretic, right? And what do we give diuretics for? We use them mostly to lower blood pressure, right? Because they decrease intravascular volume, which reduces pressure. So we might see these given to clients with heart failure because they're going to decrease the workload on the heart, right? So we need to know some things about diuretics before we can answer this question. So let's take a look very quickly at our kind of at a glance diuretics graphic here. And this comes from our diuretics cheat sheet. This graphic doesn't have everything we need to know about diuretics, but it is kind of the high level overview. So if you want more information on diuretics as a class, you can look at the whole cheat sheet on our website. So diuretics, there's a couple things that are true of all diuretics. We know that they can increase the risk for dehydration, right? Because we're getting rid of a lot of fluid. We know that because we're getting rid of a lot of fluid, we're going to see lower blood pressure, which can increase our risk for orthostatic hypotension, right? So we need to teach those clients to stand up really slowly, change positions slowly. And then also it's going to increase risk for urinating, right? Because we're getting rid of fluid and that fluid's got to come out somewhere. So they're going to be peeing more, right? And then we can categorize our diuretics into 2 categories. We have our potassium wasting and our potassium sparing. So hydrochlorothiazide is going to be what? Potassium wasting or potassium sparing? This is going to be potassium wasting, right? So we already know we're going to have increased risk for low potassium. And why do we worry about low potassium? Cardiac, right? We worry about cardiac dysrhythmias. And then how do diuretics work? If we think about this kind of from a bigger picture standpoint, they inhibit reabsorption of sodium in the kidneys, right? So sodium gets excreted, water follows it, and now we have diuresis happening, right? So if we're losing sodium in the urine, we're going to be also at increased risk for low sodium. And why is that a problem? Why are we worried about that? What can happen with low sodium? Seizures, right? Okay, so we definitely want to prevent those if we can. All right, so we already know quite a bit about diuretics. So let's see if we can use this information to go back and answer which of these would be most concerning. So our first option is increasing triglyceride levels. Is this a priority finding, do you think? Or another way I like to phrase this is this going to be a problem for me in the course of my 8-hour or 12-hour shift? Probably not, right? We know over time high triglycerides are not good. This can lead to atherosclerosis, which can increase our risk for cardiovascular disease, but we probably aren't going to see that happen over the next 8 hours. So maybe not the most concerning finding, right? We need to address it, but not the most concerning finding. Number 2, nausea, headache, and lethargy. This might be a sign of low sodium. And we said we worry about low sodium because what can that lead to? Seizures. Okay, so that is definitely concerning. That could probably be a problem within the next 8 to 12 hours of our shift. So I'm liking that, right? Anytime we have electrolyte abnormalities, that's usually a pretty big concern. But let's take a look at what else we have. On the clients urinating frequently at night. Frequent urination, is this unexpected for a client on a diuretic? No, right? We're going to expect them to be urinating more because like we said, that fluid has to come out somewhere. Now, if they're urinating at night, we might need to give some education to make sure the client's taking this medication in the morning. We don't want them taking it at night because then they're going to have to get up to go to the bathroom, and at 76 years old, that could definitely present a fall risk. So we might need to do some education, but is that most concerning? I'm more concerned about the electrolyte abnormalities than the frequent urination. And then our last option is rash on sun-exposed skin of the arms and face. Now, if this was just a rash all over, I might be more concerned about this, but this is on sun-exposed skin, and we also know that what's another common side effect of thiazide diuretics? Photosensitivity, right? So we might need to give some education that they should stay out of the sun, wear sunscreen, wear big hats, right, to protect themselves from the sun, but probably not more concerning, right, than our electrolyte abnormalities. What do you guys think? I see a lot of you are answering 2, right? We're concerned about that. Do we see if we're right? Yes, we are correct. Good job. Question number 3 is therapeutic communication. So in this question, we have a pediatric client that we're taking care of, and this client has injuries. Now, we need to read this closely, that are suggestive of possible child abuse, okay? So suggestive of possible child abuse. We're not saying that child abuse is happening. We're saying that it is suggestive of possible abuse. And we're being asked which of the following would be an appropriate response for the nurse to make to the parents. Okay, so this is kind of a delicate situation, right? We don't know exactly what's happening, but what do we need to do? If we don't know exactly what's happening, we think maybe something might be going on, but we're not sure. What do you think? We need to get more information, right? We need more info. Okay, so how do we do this? We want to do this in a very delicate way. We want to be good therapeutic communicators, especially when broaching sensitive topics like this. And therapeutic communication is not just something for mental health nurses, right? This is important for all nurses because we all have to talk to people, right? We all have to talk to families, and we want to do it in a very therapeutic way. So let's take a look at our excerpt here. This is from our therapeutic communication cheat sheet. And there's a couple things here I want to pull out for you. If we think of how do we be therapeutic communicators, the 2 biggest things is that we want to be non-judgmental and we want to use a lot of open-ended questions. And if we remember, open-ended questions are questions that can't be answered with a yes or no. So if I were to ask you, how are you studying for the NCLEX? That's going to give me a lot more information as to saying something like, did you only use one resource to study for NCLEX? That's just yes or no. It wouldn't tell me really much of anything. So open-ended questions are going to be really helpful. Let's go back and see if we can figure out which of these would be most appropriate. I see a lot of you are answering 3. So let's take a look at these and see if you are correct. Okay, our first option. Do you ever hit your child to punish bad behavior? Well, outside of this being a pretty inflammatory statement, this is a closed-ended question, right? And it's probably going to make the parent feel pretty defensive if you're just kind of outright asking them, do you hit your child? But it's a closed-ended question, so it's not going to give us a lot of information. And remember, we're kind of thinking maybe something's happening here, so we need more info. So I'm not a fan of number 1. So let's look at number 2. Your child's injuries suggest abuse. Did you cause these? What do you think? Well, again, that's a pretty inflammatory statement saying that it looks like you're abusing your child. Did you cause these? And then we follow that up with a close-ended question. So again, that's going to make these parents feel pretty defensive, right? They're not going to want to talk to you if they're thinking that you're assuming that they're abusing their child, because we don't know if that's what's happening. So again, I think we can rule that out, right? We don't want to make accusations or make the parents feel defensive because they're not going to want to talk to us. Okay, number 3, how do you discipline your child when misbehavior occurs? What do you think? Stella, I see you're coming. Rude nurse. Yes, we don't want to be a rude nurse. Okay, number 3, how do you discipline your child when misbehavior occurs? What do you think? I like this one more because we're just asking how, right? We're not implying that they're doing anything wrong. We're just asking what are things looking like at home, right? That's an open-ended question. There's no judgment there. We're just wanting to get some more info. Tell me more about that, right? So I'm liking number 3, and I see a lot of you had chose that as well. But let's make sure that we didn't miss anything. Let's take a look also at number 4. Your child's injuries will have to be reported to the authorities. This really isn't even a question, right? And remember, we said we want more info because we have injuries suggestive of possible abuse. Now, of course, if we do really suspect that abuse is happening, then nurses, right, as mandated reporters, do have to report that. But before we start jumping to we need to make a report, we want to assess the situation first, right? Get a better picture of what's happening before we decide if this is even necessary, right? So I'm liking number 3 as well. All right, should we see if we're right? Yes, we are correct. And you can see that only about 67% of users in our bank got this question correct. So you guys are doing really, really well. Our next one, let's see, this is a mental health specific question. I had to throw this in because I'm a mental health nurse, so of course I needed to include some mental health questions. All right, so here we have a nurse in an outpatient clinic who's experiencing a client who's having a panic attack. And so we're being asked, which of the following actions should the nurse take? So before we take a look at our answer options, let's just take a second to remind ourselves what panic attacks look like. So this is kind of the diagnostic criteria for a panic attack. And if any of you have ever seen someone having a panic attack, it can look really scary, right? And so these patients, when they're panicking, we think of that fight or flight system is in overdrive, right? So we're going to see palpitations, tachycardia, sweating, shaking. They feel like they can't breathe. They feel like they're choking. In short, they feel like they're dying, right? People often come into the emergency department. They're like, I think I'm having a heart attack. Like, I feel like I'm dying, right? Because anxiety can do that, and it feels very, very distressing. As nurses, do you know what our 2 biggest priorities are when caring for a client with a panic attack? If we think of our pyramid, our first one is to ensure safety, right? Because if you've ever seen someone who is panicking, you'll know that they are not thinking clearly, right? They have very much tunnel vision. They can't reason. There's not a lot of rational thought happening, if any. And so that can cause them to act really impulsively and could potentially put them in dangerous situations. So we want to ensure that they are safe until those symptoms of panic remit. And then the other priority that we have is to reduce those symptoms of panic as quickly as we can, because like I said, those clients who are panicking, they feel like they're dying. So we want to reduce those symptoms as quickly as possible. So with these 2 priorities at the front of our brain, let's take a look at our answer options and see if we can figure out which one of these are going to help us meet one of these 2 goals, okay? So the first one is to encourage the client to remain seated. Is this necessary? Do we need to make sure that they're just sitting there? No, this really, and it might not even be helpful because a lot of times clients who are panicking have a lot of nervous and restless energy, right? So just making them sit still might make them feel like they're crawling out of their skin, right? So we might do something, we could pace with them if they're feeling really restless. If you're in like a therapist office or something like that, if there's like a punching bag that they can work out some of that aggression on or some of that nervous energy, that would be fine too. But mostly this comes in the form of kind of walking, doing laps with the client, making sure that they're safe, helping them expel some of that restless energy. So we don't necessarily need to make sure that they're sitting. Our second option is to dim the lights and turn off the television. What do you think? I see a lot of people are kind of, it seems split between 2 and 4. What do you think about number 2? Is there a reason we wouldn't want to do this? That's a trick question. I like this option because what is a big part of reducing panic symptoms? We want to reduce environmental stimuli, right? Because if we think about this, so say someone comes into the emergency department having a panic attack, and we're in the emergency department waiting room, and there's babies crying, and there's phones ringing, and there's call lights going off, and there's nurses running around, and there's alarms sounding. Is that going to help someone feel less anxious? Probably not, right? Now, what if we took them back, put them in a quiet room, we turned down the lights, we got rid of a lot of that external noise, put them in a safe spot where it was quiet? They're probably going to feel like they have a little bit more room to breathe, right? So as much as we can reduce that environmental stimuli, the better. And so this is going to help reduce our symptoms of panic more quickly. So I'm liking number 2. But let's look at our other options because I see a couple people have picked 3 and 4 as well. So 3 is give the client privacy by remaining outside the room. What do you think? Outside the room. Now remember, we said clients who are panicking are not thinking clearly, right? They are probably going to be acting really impulsively because they can't think straight. So do we want to leave them alone? No, we always want to stay with a client who's panicking. We don't want to leave them alone. So I don't like number 3 because I don't know what's going to happen if I leave them in that room by themselves. So I want to keep a close eye on them. And then number 4, I see a couple people pick this. What do you think? Quick, shallow breaths. Quick, shallow breaths. What's going to happen if we tell this client to breathe quick, shallow breaths? If they're not hyperventilating, they're going to be. We don't want that. We want them to take what kind of breaths? We want slow, deep breaths, right? And so we might breathe with them. We might teach them how to do this. We want to slow that sympathetic nervous system down by slow, deep breaths, okay? So I'm not liking 4 either. I like number 2, and it looks like a lot of you agree. Yes, we are correct. And you can see only 49% of people in the bank got this one correct, so good job. I have got one more question for you, and this is a delegation question. So in this question, we have a nurse and an unlicensed assistive personnel. So this would be like a nurse's aide, a nurse's assistant, a CNA, but for the purposes of NCLEX, they call these professions unlicensed assistive personnel, so UAP. And we're caring for assigned clients on a telemetry unit, and we're being asked which of the following tasks would be appropriate for the nurse to delegate. So in this case, we have 1 task that's appropriate and 3 tasks that would be inappropriate to delegate. So we need to figure out which one. Let's remind ourselves what we know about delegation. So we can review the 5 rights of delegation. And again, this comes from our delegation cheat sheet that you can look at. We need to make sure of a couple things when we're thinking about delegating a task. So we need to ask, is this delegatee, or in this case, this UAP, competent to perform the task? So do they have the skill and knowledge necessary to do this task? And then we need to ask, is it the right task? Is it within the UAP scope of practice? Is it a routine task with an expected outcome? Does it have an established procedure that we can have them follow? Is it the right circumstance? So is this client stable? Can the RN supervise? We need to have the right communication. So did we give clear instructions? Did this UAP verbalize they understand what they're being asked to do? And can we provide adequate supervision? Because remember, the RN is always responsible for tasks, even if they're delegating. And so we need to be able to evaluate that task that was completed to see if it was done correctly, right? So let's go back and see if we can figure out which one of these would be appropriate, kind of knowing what we know about delegation. So our first option is to monitor telemetry recording for cardiac arrhythmias. What do you think? Would this be an appropriate task to delegate to a UAP, a nurse's aide, a CNA? Same thing, right? What do you think? I feel like probably not, right? Because monitoring telemetry recordings, they need specialized knowledge and training on rhythm interpretation to be able to know what they're looking at. So we might have like telemetry techs, right? But they have specialized knowledge and training in reading cardiac rhythms, right? So probably not okay to delegate. They don't have the specialized knowledge and training to do that. Okay, so we have number 2. We have a client, educate the client about the purpose of telemetry monitoring. What do you think? Is it within the UAP scope of practice to educate? No, right? That is an RN task, so not within the scope of practice of a UAP. So I don't think we can delegate that one either. What about number 3? Apply telemetry leads to a client with new onset AFib. I think people get thrown off on this one because they see new onset AFib, but can a UAP apply telemetry leads? We're just asking them basically to put some stickers on, right? That's a routine task. It has an expected outcome, right? So we know we can go in there and look and be like, yep, those leads are placed in the right spot. We can evaluate that. So I feel like that would be okay, right? We're not asking them to interpret anything. We're just saying put the leads on, right? So I feel like that would be okay. How about number 4? Adjust the alarm parameters to limit insignificant alarms. I don't like this one because insignificant alarms, who's deciding what insignificant is? And so if we just say, go set the alarms just to eliminate insignificant alarms, they're going to have specialized knowledge on that patient's clinical status to determine what is an insignificant alarm. And so we can't delegate, right? That comes from nursing assessment, knowing that patient and knowing what would be insignificant. We don't want to leave that up to somebody who doesn't have specialized knowledge and training to determine what is or is not insignificant, right? Now, if we were to give strict parameters for that, that might be a different story of like an exact number. But if we're just saying go eliminate insignificant alarms, that's probably not going to be okay, right? Okay, so that leaves us with 3, and I see a lot of people chose that. So what do you think? Were we right? All right, yes, we were correct. 54.5% of people in our bank got this correct. So you guys are doing really, really well. So that was our last question. So I'm going to leave you with some links of where you can find us. So you can find us at bootcamp.com/NCLEX. And so that is where you can find a lot of the cheat sheets with some of those excerpts you saw of them today as we kind of talk through some of these questions. And of course, you can follow us on Instagram and TikTok and YouTube where we're at today. We are on Facebook as well. So if you're looking for a little bit more camaraderie as you're studying for the NCLEX, because we know that can be such a stressful time, you can come and join our Facebook group as well. And of course, if you have any friends or cohort members, you can invite them to our Facebook group also. That is all we have today. Next week we have, what do we have coming up? Next week is going to be Next Gen NCLEX with Dr. Emily. So she is going to be talking all through the next generation NCLEX, what you should expect, some tips and tricks to help you feel more prepared for that. So join us then. Usually they post on Instagram and Facebook when those live webinars are, and of course they're archived on our YouTube page so you can watch them if you can't make the live webinar. So thank you so much for participating today. I love seeing all your answers. It makes it a lot more fun. And Amber's still there in the chat. If you have any questions, let her know. For all of you who are taking the NCLEX soon, I wish you all the best of luck. If today is any indication of how you're due, I am sure you're going to do fantastic. And thank you so much, and I will see you all again soon.